everyone. I'm Aida Trabulce from Baylor St. Mexico representatives. I'm presenting you Dr. Nabil Mansour. He is the director of the Gastroenterology department in Baylor St. College of Medicine. So, welcome, Dr. Mansour. Please present yourself.
Thank you for having me. I'm Dr. Nabil Mansour. I am a general gastroenterologist at Baylor College of Medicine and Baylor St. Medical Center in Houston, Texas, and I'm very happy to be here.
Thank you, Doctor. I'm going to give you some questions. Can you help us, please? PPI studies span decades. For new known endoscopic therapies that aim to be a definite solution, what in the 5 to 10 year follow-up data demonstrating their durability and sustained reduction in the risk of progression to Barrett's esophagus compared to chronic medication?
So, anytime we're talking about any types of therapies or new therapies, the durability of the therapy and the effectiveness and the durability over time is very, very important. So some of these newer procedures that we have, like TIF or transoral incisionless fundoplication, we have very good data right now to cover at least 5 years, and some additional data that covers even a 10-year span that shows that these procedures are effective and durable, with 80 to 85% persistent success rates after 5 years and around 80% after 10 years. There is a small number of patients that do require sometimes having to go back on PPI medicine, but even when they do, it's usually at a lower dose and less frequent than it was before. So there's very good data on these procedures right now, and it's showing that it's effective and durable, and hopefully with more time and more volume of these procedures, we'll be able to collect more data and have more data in the future. Now, one thing that's lacking is, you had mentioned Barrett's esophagus. We still don't have a lot of data specifically showing how these procedures decrease the risk of Barrett's esophagus. We do know that PPI medication can decrease the risk of progression to Barrett's esophagus, but we're trying to collect more data and more information on how these procedures can actually directly affect the risk of Barrett's esophagus. But for the primary symptoms of acid reflux and acid control, we do know they have 80 to around 85% success rate.
Okay. In your opinion, do you believe the main barrier to effective GERD management is insufficient diagnosis of the underlying causes, or the underutilizations of advanced diagnostic tools such as high-resolution mammometry and pH metry is primary care?
Yeah, so I do think that the biggest gap we have right now is the underutilization of diagnostic modalities that we have for acid reflux. Many patients are just empirically put on a medication for acid reflux based on their symptoms, and that is a suitable approach for some patients, but it doesn't work for every patient. It is important, especially in certain select patients, that we do diagnostic modalities, including pH monitoring, ambulatory pH monitoring, as well as high-resolution esophageal manometry in these patients to check for any other underlying disorders to confirm the diagnosis of reflux. And if we are considering any of these more advanced anti-reflux therapies, at our program it is a requirement to undergo that type of testing so that we can make sure that we're only offering these therapies in the patients that are going to be most likely to succeed from it.
Beyond radiofrequency ablation for Barrett's esophagus, what is the next technological frontier in the endoscopic field for detecting and treating esophageal cancer in the earlier stages with the least possible invasiveness?
So right now we have radiofrequency ablation, we have cryotherapy, a newer modality, something that's called hybrid argon plasma coagulation, which is being used in some patients. These modalities are all very effective and safe, and they're not very invasive at treating Barrett's esophagus. Where some of the more exciting technological advances are coming in Barrett's esophagus is with risk stratifying patients. We're trying to determine which patients are going to be more likely to progress. One of these new modalities is something that we're doing now that's called TissueCypher, or a tissue systems assay, which checks for biomarkers, which can allow us to better identify which patients with Barrett's esophagus are more likely to progress to a more advanced form of Barrett's esophagus or to progress to cancer, so that we can then target those patients for therapy as well.
what is your visions for the use of artificial intelligence in the short or medium term to improve detection, diagnosis, risk prediction, or post-procedure management of patients with Barrett's esophagus?
So artificial intelligence is a big topic. It's an exciting topic. It's a topic that's affecting many different areas of medicine. In gastroenterology, we're already using artificial intelligence as part of our colonoscopies to help better identify colorectal polyps and precancerous lesions. We're also trying to implement it into our clinic to make us more efficient in the clinic. But in Barrett's esophagus, there's been a lot of research that has been done on potential AI applications in Barrett's esophagus. Tools that use AI, computer-aided detection and computer-aided diagnosis to allow us to better identify and diagnose patients with Barrett's esophagus and those that have higher risk forms of Barrett's esophagus, such as dysplasia, that might warrant more aggressive treatment or more aggressive therapies. A lot of these tools are being used currently in research settings, but we hope that in the very near future we're going to be able to bring these to routine clinical practice, and that's really going to help move our practice forward and allow us to better care for these patients.
Thank you very much, Dr. Nabil Mansour.